Hi, everyone. So, welcome to our June session of Community Health Learning Collective, also known as CHLC. I am Maureen Burns. I'm here with my partner in crime, Candace Straw, and we are your hosts at the HAP Foundation. We're two community health workers at the HAP Foundation, located in Chicago, Illinois. And this is Community Health Learning Collective. For those of you who are new to the group, we are basically a shared online learning space for community health workers, promotoras de salud, CHRs, and our allies. So every month we come together to share space and we feature speakers who are sharing knowledge that's valuable to us as community health workers, or valuable to allies, or valuable to people who just care about the health of those in their community. So as I said, Candace and I are here in Chicago, Illinois. We do have group members from all over the country, from different states. And so it's really great to see the group grow and sort of learn together and learn from one another. So we are in June of 2024, believe it or not, kind of wild. I'm going to go ahead and introduce our speaker. So we're super excited to welcome Joey Medler, who is a licensed clinical social worker. He will be our featured presenter. He provides therapy and clinical consultation in his private practice, Medler TX Incorporated. And he's also the Associate Director of Therapeutic Services at Howard Brown Health in Chicago. And he's also a consultant and member of the Sexual and Gender Minority Work Group for the National Opioid Response Network. So that is sort of an abbreviated version of his bio, and he's going to be sharing some knowledge and skills with us today around harm reduction. So thank you, Joey, and take it away.
Thanks, Maureen, and thank you everyone for being here, especially for a topic that is so dear to not only just my heart as a human being, but just my clinical work as well, my clinical heart, as I like to say. And so we'll be touching a lot about harm reduction. I mean, it is a big topic, and it's a lot for an hour and a half. And if you've ever taken a workshop from me, I prepare a lot. So I'm going to give you bunches of information around the history of it, practical applications, and hopefully some time for questions at the end. So if at any point I'm going too fast, or if you just have a question, please feel free to just interrupt me at any point. I'm happy to stop, full stop there. And I'll also try to keep one eye on the chat as well. But yeah, let's start the show, shall we? So hopefully many of you are familiar to the concepts of harm reduction, but we will definitely be covering that today as well. But, because we are talking about harm reduction, that means that we do talk about substance use today a little bit. Now, harm reduction is just not about substance use. It's about so much more than that. But I just want to take a moment to encourage you all, please take care of yourselves. If there is a topic that's being discussed or something that is, going on that maybe is bringing some internal reaction for you or experience for you, please take care of yourself. Maybe that's going off camera, going for, a quick break from the computer. Please, I will not take any offense to that. But yeah, just definitely take care of yourselves, okay? Because, it is a powerful conversation, I think. And so I hope after today's conversation, it can be a little bit easier for you to kind of bring that more into your life and maybe see the broad aspect of it all. So I've already kind of gone through a little bit of learning objectives for today's conversation, but what I really want to do is take a moment, and a very serious moment here, and provide some context in terms of, before we go into the history of harm reduction, understanding the social politics around substance use. And so what I'm going to give you is two historical quotes that do have some powerful language and words being used in them. And I give you this for the context to understand why it's taken so long for harm reduction to really kind of gain some tread and momentum, especially here in the United States. So what I'm giving to you all is a quote first from Harry Anslinger from the testimony to U.S. Congress supporting the Marijuana Tax Act of 1937. And then the second quote is from the former Nixon Domestic Affairs Chief, John Aukerman. In both of these quotes, you can see that the concept of the war on drugs has never existed. There's never been a war on drugs. It's been a race war the entire time. It's been a sexual war the entire time. It's been a marginalized community war the entire time, but it's never been actually about the drugs themselves. And so I give you these powerful quotes from people to really, again, set the stage as to why. Why has this been so challenging for people over time? And really, it's because of this intersectionality of oppression, racism, homophobia, um, shame, stigma, right? When we think about stigma, we think that in conditions that people are oftentimes stigmatized are the conditions in which the observer or the community abroad or whoever is observing the situation is viewing that person to be in control of the situation. When there's a belief that this person had control of their own decisions and behaviors and could foresee everything, stigma starts rearing its head. It's like, well, you should have known, you know? But if we perceive the person as having little control over that, stigma doesn't rear its head so much in those moments. And so when you add that to the stigmatization of these identities, you can see hopefully kind of where I'm going with some of this. In the United States, it's been around definitely since the 60s. Internationally, harm reduction, the concept of it has been around really just since like the 50s or so. But it really didn't come here until about the 60s and 70s because we put so much abstinence focused programming and especially when it comes to like grant money. I mean, over the last 15, 20 years, if you mention the words harm reduction in your grant proposal, you were not going to get funded. You are not going to be picked up. So people got very clever with ways to do research around this without using those words. And that's what I love about these people in the world, because we will find ways through the tape if possible. And so it's just really until over the last couple of years that research using specifically harm reduction as key terms is actually being funded and published. And that's definitely in the help of the growing belief in harm reduction, specifically spearheaded by SAMHSA, who recently made the decision to alter their name. So it's still an acronym. I mean, that's going to be billions of dollars of marketing change out. So they're not going to change that. But instead of A being for abuse, it's going to be substance use and mental health. So that's a huge fundamental change in the concept of what we're working with here. And it also shows just the way for research is giving birth to in our country. So what did it really look like early on? Early harm reduction was really brought out by communities, the BIPOC communities and transgender expansive communities. And you're right, Maureen. I mean, it is so sad that this has been viewed negatively, except for these communities who realized the power of it. So some examples I can give you are trans women of color providing safe housing to their fellow sex workers, or even in the house scene that was big in the 80s, right, in the 70s. And so that was also a theme of harm reduction, to provide basic needs to help someone live their life. Punk women of color collecting sterile syringes, the Black Panthers and the Young Lords. Look at what these communities are doing, because they realized if we don't do something and marshal together as a community, more risk and harm is going to be done to us. No one else is doing it. And so here we go, some prime examples of how these communities that are oftentimes marginalized, discriminated, they came together and they created it here. So awesome, fun little history fact for you there. But when we think about the most well-known examples of harm reduction, especially in the United States, there's two big things that most people think about: the HIV/AIDS epidemic and the crack cocaine epidemic of the 80s. These are really the two historical moments of time where most people really started understanding what does harm reduction actually mean. And the reason why is because, right, this was a whole nationwide situation, right? It wasn't localized to a community in South Bronx or things like that. This was a nationwide, this was a worldwide epidemic. And so research started coming out to say, hey, we need to do something about this. Now, those quotes that I showed you in the beginning of today's talk help to underscore why there was that strong political opposition to all this in the very beginning, even though the data was there. The researchers and the activists came together and they said, if we can give people these materials to lower transmission and provide safer methods of sex and substance use, we can reduce this. And even though the data was there, the political beliefs of the time were still barriers, right? So over time, they kept picking away, and what they finally found was the key was to show politicians that through harm reduction, you will save money. Money is a very powerful factor in this world, especially in politics. And I'd be amiss as a social worker if I do not acknowledge that. And so when we look at money, all the public advocates and the researchers came together and showed, look, if you can provide harm reduction, you're saving the cost of hospital bills, funeral costs, all these things that are being absorbed by the state because nobody could pay for it. So that started changing the tide with some things here. In the 80s, it was about like the later 80s, that's when needle exchanges really started coming around on the scene. Because again, it was from the fruition of all the research and the data that was being done during this time. About now, there's about 300 needle exchanges that are operating in the United States. However, that is still not an accurate number. Why? Because the vast majority of these are run by state or local county officials. And we know that for some communities, that is a huge barrier, right? And so I can assure you that there are needle exchanges happening all over this country in the underground that the state doesn't know about. So I've got dear friends that host potlucks on reservations. And at the potluck, they bring out all the supplies and they share them with the community. I know people who do it in the back of their trunk in rural Iowa. And so get the supplies out there. But it doesn't need to always be necessarily controlled by these larger entities. Because again, stigma, shame, discrimination, right? A little bit of some stats about numbers here. And this is why, again, harm reduction is so important because yearly we spend about $120 billion into healthcare, and that's for inpatient and outpatient care for substance use diagnoses. Yet we know that further digging in the research, not many of those people actually have a substance use diagnosis. Many of them are mandated to treatment by the courts, and that was really based on possession alone. As I can show you that for 86% of the drug law violations just in 2020, 86% was just for possession alone. That doesn't, clinically, that does not meet a diagnosis, just to possess a substance. Looking at the racial disparities, again, in this greater context of politics and racial identity within substance use and harm reduction, 27% of those arrests were Black individuals, despite being only 13% of the 13.6% of the population. 2/3 of women on probation are white, while 2/3 of women in prison are Black. And 70% of women identify as the primary caregiver of children when they're sentenced to prison. So this is a very big conversation here, right? And there's a lot of things that are mixed up in here. So this is why it's taken so long for harm reduction to really kind of come around and decriminalization, because again, these are some scary numbers here, right? And the ways that it's being marketed, targeted, and weaponized against certain communities. I just want to zoom out, give you a big, broader context as to kind of how this can play out in the longer run. Portugal, some of you might have known that back in Portugal, they did the decriminalization on the public and private use of substances. And what they did was when people were arrested, rather than being charged and sent to jail, they sent them to this commission who did an assessment of everything that was going on. And they found that, again, same to our data, the vast majority of these individuals that are being arrested, none of them met actually any clinical criteria for a diagnosis of substance use disorders. So 10% really were. And then what happened was a lot of those individuals needed case management. They needed their basic needs met. They needed housing. They needed employment. That's what the commission did. They started getting individuals into those more supportive services. And across the board, their country lowered the cost of treatment 60%. Well, they increased the access to treatment by 60%, but also the cost, right? Because they're focusing on those that actually met the clinical diagnosis and the criteria for the treatment versus putting people through that really just needed their basic needs met. Some really interesting numbers. So in overdose deaths, back in 1990, they had 368, dropped down to 30 in 2016. You can also see the significant drop in HIV diagnoses. Now, if you've been keeping up with the story, recently over the last few years, these numbers are on the rise. And people are starting to create the narrative that, well, this just shows that harm reduction doesn't work. Absolutely, it does. There's just always going to be a new factor that comes into play. There always has to be, the new substance, the new factor of whether it's barriers to public aid or housing that's going to play into this. But it's not just about harm reduction not working, because we can see for many years it did, right? Another example I want to give you is Spain. So one of the first countries in the European nations to utilize a harm reduction approach, especially during the HIV/AIDS epidemic, which was very big during the time, they saw a 72% decrease in AIDS-related deaths. So again, just another kind of showing of, how we need to pull away stigma and discrimination and really look at the root cause of what's happening here. And a little quote that I like to share is that the moral concepts and prejudices that hinder legislation and interfere with the implementation of medication-assisted therapy, MAT, has been more influential in the treatment of opioid dependence than the scientific evidence. That's big, right? Because we see that in our own country from some of the quotes that I gave you. How are we doing so far? I know I just gave you a lot of numbers here. Just want to take a breath. Any thoughts, questions, concerns so far? No, doing okay? All right, perfect. Let's bring it back to the US. So in the US, collectively, the CDC has been doing a lot about promoting syringe service programs. So needle exchange is another term for needle exchange. In fact, actually, the SAMHSA just published, I think it was March of last year, their first ever data reference guide for harm reduction and needle exchanges. First ever. And what's also really cool about that was it was 10 years in the making, utilize people with not only lived experience, but also academic and research background around harm reduction. And here's a fun one. First time they ever got paid for it. Boom. So thank you, SAMHSA, for actually paying people for their knowledge and experience, especially around harm reduction. So that's really cool. We've got the Office of the Assistant Secretary of Health, the Surgeon General. Everyone is starting to realize that by promoting syringe service programs and harm reduction, we're helping our communities. New York, back in 21, opened the very first state-operated safe injection site. So a dirty word that is oftentimes associated with this is a shooting gallery. That might ring some bells for some people, but a safe injection site place is for anyone to come in. They have a sterile, safe environment for them to engage in their relationship with whatever use that they have. They've got medical staff on site. They've got community advocates. They've got housing and employment resource specialists. So very much like Portugal did, New York kind of did the same thing. So kind of amazing the ways that they've changed the overdose scene in New York. They, treated 672. They still have plans to open up more. The mayor himself said that we must ramp up our efforts to prevent fatal overdoses and get treatment to people who need it. This plan would expand proven harm reduction and treatment strategies with the goal of reducing overdose deaths in the New York City by 15%. So super exciting stuff happening in New York. Same thing in Rhode Island. I was just at the Opioid Response Network's yearly summit last year in Rhode Island and got to meet the governor there, who talked about creating their pilot program where, again, same thing, providing a safe injection site for individuals. But now this is not necessarily being run so much by the states. It's actually organizations that can apply for the grant funding that, yes, would be, overseen in the state in some way, but it wouldn't be a state site that this individual would go to. It would be a community-based organization that they would go up to, and that would then provide them the same thing. So medical and behavioral health providers, peer specialists. So again, a safe space for people to go rather than, engaging in use in, let's say, a abandoned building or in the middle of the woods, where if they're alone and they overdose, who's there, right? Oregon has also been doing a lot of stuff recently over the last couple of years. You may have heard about Measure 110. And so what the purpose of that is to make the possession of small amounts of what have been considered harder drugs a violation. There is a whole hierarchy of drugs in the legal system, which I find very fascinating. When people say meth versus alcohol, two very different pictures show up in the legal sense. And so depending on what substance it is, you're going to be punished harder. So Oregon has been trying to revoke that and make it on the same level as like a traffic ticket. So again, that data around the possession alone, all of that is going to help eliminate those criminal penalties because, again, they're lowering down the severity of these things when really, they should, I think, at this point. I mean, it's amazing the stats again about the legal numbers with all this. So kind of excited about what Oregon's doing right now. And they're still working on it. It's been a couple of years. Obviously, there's a lot of pushback, but that's big in that area, I would say. So as you can see around the world and in the US, a lot of stuff has been happening over the last, several decades here. And we're really getting to a point where we're realizing that it's not just abstinence and harm reduction and treatment, it's both holding hands because humans are not just only abstinent or only focusing on harm reduction. There's different aspects of that in everything that we do in life, which we'll kind of go into in just a minute. So setting the frame now in terms of harm reduction as a tool and what it is as kind of a philosophy, it's all about creating practical strategies for people. And practicality is a very important thing because these strategies have to be things that somebody can actually do. When we engage in harm reduction, we don't want to work with somebody who is without all their basic needs and then tell them, harm reduction would be, using in a place that's, well lit and, safe and not in a building. And if this person has absolutely nothing, that's not a very practical strategy that we're giving them. It's all about creating a spectrum of strategies, or I like to say a buffet of strategies. I love buffets. That's the only reason why people go to Vegas, well, maybe concerts, but the buffets are excellent, right? It's all about meeting the client where they're at. So that's understanding the motivational for change, the level of use, the relationship of use that they have with the substance. And of course, it's not about minimizing the harms here. So I definitely identify as a radical harm reductionist, which means that I will go to the nth degree to be with you and by your side. And during that process, I will still talk to you about neurochemical exhaustion that's caused by stimulant use. I will still talk to you about the liver impact caused by the opioids. I will still give you those facts and work on practical strategies to meet you where you're at to elicit further change. So as a harm reductionist, and it's not about, you can do whatever you want. We're still talking about the risks here. The big thing about harm reduction is that we don't use judgment. Judgment doesn't help really anything, because it just leads to shame, it leads to guilt. And for many of us, we were taught that early on, right? And so whether that comes from our cultural background, our religious background, whatever intersectionality of identities we have, all of us have experienced that sense of shame and guilt. And when we use judgment, especially in treatment, it just pulls up those same feelings, right? And so you're right, abstinence does shut out a lot of people because it's just saying this is the one way. That's not really realistic, I don't think. Especially when you look at a lot of the meta-analyses about abstinence-based programming, shortly after treatment, sure, usually the person's doing pretty good. After 30 days, after 60 days, the rates plummet. If you look at the research that incorporates both harm reduction and abstinence, the efficacy of the treatment and the longevity of it goes far longer than an abstinence only program because they're looking at life as the greater whole here. I think, and granted, this is certainly a bias, and I'm recognizing that. One of the complications I have about abstinence only based treatment and programming is if you think about a relationship with substance use like a flower, abstinence oftentimes really just looks at the flower head. And if you snip off that flower head, what happens? You leave the roots. The roots are still there. So when we look at harm reduction and the incorporation of that in treatment, it's to look at why. Why did this flower grow in the first place? There is something that drug is doing. Let's find that first, right? Because that will absolutely help us to kind of figure out, what it is that we actually have to work on in treatment. Deflection initiated across the state. Oh, absolutely. Yeah. So yeah, deflection specialist, one of my friends is working on that program itself. So thank you very much for mentioning that, Greg. So again, another great example of, looking at how we can prevent further harm from people. And we'll also talk a little bit about that, about reversing an overdose, because overdoses involving the legal system can definitely be problematic, right? So deflection of things is always a great process. What is it not? Harm reduction is not everything goes. It's not encouraging use. It's not dismissing or excluding abstinence. If you want to bring that in, great. I'm going to bring that in with you. We were going to find a beautiful tapestry that we can weave together of harm reduction and abstinence together. And again, it's neither careless or indifferent, because again, we have to be very specific about what we're doing here. Harm reduction is about reducing risk. So you can't just go into that with a very haphazard kind of mentality, because how are you going to reduce the risk if it's just careless or indifferent to what's really going on here? So like I've said, harm reduction can be a very big concept here. And so this is some of the examples that I can give you. Harm reduction is wearing a face mask during a pandemic or an epidemic. It is using Narcan. It is getting vaccinated. It is having AEDs in public areas. The number one example I ever give anyone around harm reduction is a seatbelt. It is something that you are consciously choosing to use for the purpose of reducing risk. Boom, that's harm reduction. And so I like to bring it down to very, again, practical and specific examples for, individuals that might be struggling with, how can harm reduction work in daily life? It already does. We already do it. And here you go. Checking in, questions, thoughts, anything about the list that's surprising, anything so far? Going once, going twice. All right, I like this crew. All right, hopefully you're digesting it.
We're digesting it.
Oh, yeah, Candace?
I say we're digesting it. Some good teaching.
Excellent. Thank you. Thank you. I always wonder if I'm going too fast. So how does this work? It's utilizing that gradual approach to change, which almost all humans operate from. Change is not a very quick thing. We're capable of doing it during emergencies and moments of upheaval. Sure, we're pretty adaptable human beings. I mean, we've lived on all 7 continents, in the middle of the desert, in Antarctica. We have people living there right now. And yet it's still a process of change for us. So harm reduction is acknowledging that if you want to get from, let's say, injecting heroin 5 days a week to 2 days a week, that's still going to be a process of change that we need to work out. That's not going to happen overnight. Not to say it can't, but it is very unlikely that's going to happen unless there's a significant factor that's saying otherwise. And so we really want to look at this idea of the rock bottom that's oftentimes used in treatment language, which I find extremely problematic because it's perpetuating this idea that people just don't change unless they have to hit this rock bottom. You have to get so bad that that's when things can happen. What if we prevented that rock bottom? What if we just started now and then moved forward? So in HIV treatment, a long time saying is treatment is prevention, and prevention is treatment in the same right, in a way. So this is the same thing. Let's prevent the rock bottom, because if you hit that rock bottom and let's say you've lost some of your basic needs or you've lost your social support network because you hit that rock bottom, it's going to be far harder for you to climb out of that hole now than it would have been if we just maybe applied some harm reduction or some practical strategies to prevent that from happening. Harm reduction is really not only a philosophy, it's a way of talking to people in this world. And over the last decade, as I've been practicing harm reduction, it has become just part of my lexicon. It is my daily way of talking to people. And so in this language of harm reduction, we don't use words like addict, alcoholic, abuser, druggie, tweaker. We don't use any of those words. Now, a lot of people ask, well, Joey, what if your client wants to? What if your client comes and says, you know what, I'm an alcoholic, I'm an addict? I will hold those with you. And I'm going to ask you, what is the purpose of using that word? What does that identity mean to you to refer to yourself, to see yourself as an addict? What does that mean? Tell me. That's what I'm really curious about. Is that, like, how does this word have power in your life? And what is that going to do for you? We don't tell a person who doesn't exercise to run a marathon tomorrow. Exactly. Yes. Oh gosh, marathon. Yeah, building up to things, right? Exactly. Great example for that. Thank you. And so we really want to look at why people use certain languages, but also find ways to help them see beyond that. But again, I'm not going to tell my client, you can't call yourself an alcoholic. That's not my place. I'm going to ask you why. Again, it's usually because shame and judgment's late in there. It's also person first. So it's the difference of the client is John Smith, who currently has a relationship with alcohol that he's wanting to work on in therapy, versus the client is an alcoholic named John Smith who wants to work on his drinking in therapy. Two very different ways to refer to somebody. In the first example, we're putting the person first, and then we're referring to it as a relationship with the substance. In the second, we're labeling this person as an alcoholic, which is a judgment, before we even name who this person is. And then we're talking about this drinking, but it's not really about the relationship of the substance, which is a bigger aspect in the clinical work. As you saw in the previous slide, from all the examples of harm reduction can be social harm reduction. It can be financial harm reduction. Financial harm reduction is that moment of saying, okay, I've got $80 left. I can buy food. I can buy an 8-ball of Coke. I can buy a gift for mom because Mother's Day is coming up next week. How do I want to allocate that money and reduce the risk to not only myself, but maybe mom, or being able to provide for my nutrition? That's a little example of how financial harm reduction can play out here. And also spiritual harm reduction, the ability to find a connection with humanity and life and building that up. So harm reduction is all about life, as you can see. So I don't want to just narrow this on substance use, but show the greater aspect of it all. The 6 principles: health and dignity first and foremost. We are all about the health of the person and the dignity of the person. They are centered in the process, they're involved in the process, and they have self-rule, which means that they get to determine what's going on. So self-rule, an example of that is, Joey, I want to work on my cocaine use, and I know I use daily, and right now my goal is to go down to 2 days a week. Okay, that's your self-rule. Let's go there, and then reevaluate, and by centered and involved, what I mean by that is that they have to be part of the treatment plan itself. So we are not just putting goals on a treatment plan without their buy-in. That's, in my book, that's not right. That client should be sitting there creating those collaborative goals with you. Because if they're not part of that process, it's really hard to get them to be part of the process if they're not part of it in the first place, right? And then, right, to Greg's point here, centered, we need to look at the intersectionality, the holistic whole body aspect of that person and bring it into treatment. So, for example, what I mean by that is somebody who is not a part of the queer community but specializes in queer health. What I find really interesting is when I have a client who wants to go to, let's say, an intensive outpatient program, an IOP, or they want to go into an inpatient program, and I pull up that hospital, let's say, and they say, we provide LGBTQ plus healthcare. Okay, you see where I'm going with this? So then I call them up and I ask, hey, I got a client who's queer, actually, trans female, and I'm thinking, just what treatment programming do you have specifically that you mentioned on the website? Can you tell me about that? Oh, well, right, yeah, well, it's the same treatment program. We're just being mindful of who they are. Okay, yeah, but can you explain how that works? And it's silence. There's actually research that was done by a group of friends of mine that did that. They called over 300 treatment centers all over the entire country that said that they specialize in LGBTQ plus healthcare, and over 86% of them actually had no idea what they were being asked about. So, participant-centered, we need to bring in that person's identity into the treatment. And because once they leave that treatment facility, they're going back in the community that they're from. So if we didn't bring that community in there, what happens when they go back out there? Same thing is going to come back, right? Of course, recognizes the inequalities and injustices. I've definitely made, I think, that case so far in all the data. And again, practical and realistic. For anyone who's a clinician, if you haven't heard of Pat Denning and Jeannie Little, they are the founders of the Center for Harm Reduction Therapy in San Francisco. They also wrote the Harm Reduction Psychotherapy, Great book. So definitely suggest checking it out. And it really goes into how to incorporate this within therapy as well. So as Pat says, it's an interactive phenomenon in which the relative weight of biology, psychology, and social factors varies for each person and for each drug. And so what they mean by that, again, that client-centered, that whole person aspect here is bringing that in so we can see how that phenomenon plays out for each individual person and not just this blanket approach to treatment, essentially. I met them 2 years ago at the National Harm Reduction Coalition Conference in Puerto Rico. I think I terrified them because I totally like fanboy geeked out on them, and I charged at them, expressing my joy and wanting to take a picture of them. They did, but I think I terrified them a little bit. In harm reduction psychotherapy, it is the understanding that not all use is abuse. People have relationships with use. It occurs on continuums. So as I teach my graduate students every year in our clinical training program, I ask them, if you have a client that comes up to you and says, I'm drinking every day, do you think this person has an alcohol diagnosis? And the vast majority of students, when they start the program, say yes. And then I remind them, the only thing you know about this person is how much they drink. That's not enough for a diagnosis. That just means that they drink that much. How long are they spending on it? How much has it impacted their work or social lives? What withdrawals do they have? All those other factors and criteria that we're looking at, that needs to pull into that. What I really love about harm reduction psychotherapy is that we don't refer to people as having addictions. They have relationships with substances. And we acknowledge that people use for certain reasons. It's for giving them some kind of function. Maybe it's giving them, for many of the clients that I've worked with who are disenfranchised, marginalized, and discriminated against in daily life, using is a way for them to get a place to sleep that night. Joey, I got a place to sleep last night. The trade-off was I had to use with them. Okay, what was that like? What can we do to promote safety for you going forward? And I'm still acknowledging that that got you out of the park last night, which probably was going to be a lot more dangerous for you, especially if you're in Chicago here and it's 98 degrees. That is a very dangerous place for you to be in overnight. So again, we want to really just look at the reasons there. We want to look at what it's being used, the aspects of the person. So what kind of characteristics are happening that might impact the relationship with the use? And then how are they using it? So like the physical setting, maybe even the social setting. So those are the kind of the 3 key aspects that are based within harm reduction psychotherapy. They definitely honor the avoidance and the hesitation towards seeking treatment. We get that, right? I mean, look at the history of treatment, especially for communities of color and trans and gender expansive folk in healthcare. It's not a pretty picture. It has never been for decades, hundreds of years. So there is a clear and understandable avoidance to going to an inpatient program, especially if you are a young trans woman. I get that, because who knows if you are going to be allowed on the floor for female identified folk. Not a lot of places actually allow that. So I'm not going to put my client into harm and putting them in a space where they cannot have their identity being honored. We're really looking at the coping skills, the greater picture, right? Because again, think about those roots. You can cut off the flower head, you still have to deal with the roots, the functionality of that. So it's not about substitution as some people think of swapping out one thing for another, but it's realizing that if we pull this thing that's giving you some measure of comfort in your life, granted it could create fires around your life, but it's providing some comfort. If we pull that out, what goes in its place? Something has to fit. We definitely discuss the meaning of finding safety during times of emotional distress, which is oftentimes building the relationship with substance use. Joey, that helped me get those feelings out. Or Joey, it helped me numb. I did not want to allow myself to have those feelings. And so I used and I didn't have to feel anymore. Okay. What does it mean to feel? You know? And again, harnessing that intersectionality of the client. One thing I work on in treatment is building a sense of community and social support. I really want to bring in some sense of community identity into the treatment because that's where they're going back out to. You know, once they see me for 45 minutes for an hour, one day a week, they're out in the community the rest of the time. So I want to bring some of that in. All right, let's go into the buffet of options here. So what we're going to do here next is we're going to go through various types of use. So injection, smoking, snorting. I'm going to go through some practical tips through each of those methods of use. And then we'll enter the last part of our conversation today, which is how to spot and reverse an opioid overdose. Okay. So let's start with intravenous use. In some using communities, this is referred to as slamming, especially in the stimulant use community, like the meth community, oftentimes known as slamming. The big thing with intravenous use is, with any use really, of course, never use alone. We definitely do not want to share needles. I'll show you a slide next which kind of shows the reason why. Outside of just the chance of infection, that needle is not a perfect point after that first use. Back in the day before I was a social worker, I was also a trained phlebotomist. And please, if I can give you one thing to take away from here, when you go and give your blood, do not allow two things to happen. One, that person to stick you, pull out and use that same needle to go back in. Do not let them do that. Grab their hand and tell them to get a new needle. The second thing is when they go in and they start fishing around because they didn't find the vein when they first went in. Now, we do not fish around and break people's insides. So if they didn't get the flash of blood in that first poke, you get a whole new needle. Please do that. We really want to make sure that we're using sterile needles. If that's not possible, harm reduction, we rinse it out. It's best if we use kind of bleach water. If there's just water, something. But that's, bare bones harm reduction. But of course, best would be a clean, sterile needle every single time. We also want to make sure our injection site is sterile and clean. So we want to make sure we got our alcohol swab or our warm soapy water to reduce infection. And of course, aftercare, right? So here's what a needle looks up microscopically. That's your brand new needle on the top left, right? That's a beautiful point on a needle. After that first use on the top right, if you can see in the picture, there's already a bent there. And by the time it's used 6 times, that looks like a fish hook that's going in you. And that's why we're getting all these broken vessels and veins, because these needles are just being used over time. So this is exactly why I do not let that phlebotomist take your blood twice with the same needle. All right. Another few points about intravenous use, starting with a tester shot. So using a little bit of the baggie or the amount that you've got is a great way to not only test a few things. One, your tolerance. Your tolerance goes up and down a lot. Your tolerance can be based on how nourished you are, how dehydrated you are, how tired you are, how much you've been using recently, how little you've been using. All that changes your tolerance. Also, what you're using changes. So depending on if you're getting your supply from multiple dealers, which is definitely not a harm reductionist thing, you might get different batches and different strengths of things versus having one dealer, one supply kind of a thing. And again, that can still change, right? So it's all about knowing the relationship with the dealer and who's getting what from where, and also empowering people to be able to test their own supplies with maybe fentanyl testing strips. We'll talk about fentanyl in just a minute, but being able to test that tester shot gives them that moment to be like, okay, this is what I'm feeling. Do I want to continue doing more of this based on what I'm feeling now? Okay. We also want to make sure that they have naloxone or Narcan, just in case of anything. Taking turns. So using 30 minutes apart can also help to have that window of a potential overdose. It also keeps one person kind of aware of what's going on. Another great suggestion is there are never use alone hotlines where people can call and there's a live person that's on the other phone with you and they're going to stay with you. And if you start nodding off or if you start going into an overdose, they have already created a plan with you and they're going to act on it if you nod off on that. So another great resource that's out there. And of course, you want to go slow, right? Because again, tolerance can change all the time. When it comes to smoking, a couple of unique things here is we're going to think about our mouth. So we're going to think about the power of our mouth and our oral health. So one thing I've oftentimes coached people around is as we think about sleep being the gateway for our emotional and mental health, our mouth is oftentimes the gateway for our physical health. This is the great first barrier to things getting into our body, right? So the health of our gums and teeth are going to be one of the baselines of how potential risky it is to smoke things, right? Because if our gums and our teeth are not in a healthy state, more potential chance for open portals for things to come in, infections into the gums. So when it comes to smoking, we want to think about using a like a glass pipe. That way they're not burning themselves on metal. There's also what we call spark plugs, which are like a plastic end that you can put on the glass pipe. So that way they can protect their fingers even more so from the glass. In the picture, you can see a little bit of copper wire in the bottom left of the smoking kit baggie. So the copper wire helps to filter out whatever it is that they're smoking. So that's another added barrier to kind of bringing in any impurities into the mouth. In the baggie, you can also see a little bit of what looks like a bamboo stick. That's to go through the glass pipe itself to clean it out between use. And chapstick. So we think about the heat of the flame, right? And also just the smoke in our mouth, and so all that can absolutely deteriorate our gums and our lips. And so we want to think about using chapstick after we're smoking, because that way it helps to restore our gums, gives that moisturizing effect to our lips. Same thing internally, drinking some water before and after to keep that mouth wet and moist. Dried gums, dried mouth, more likely to crack and open up from the heat. So keeping that mouth wet. Also, depending on chapstick, I know chapstick can definitely be expensive for some people. Maybe getting a big tub of Vaseline can also do the same thing on those lips. So preventative measures before and after to heal that process of the skin after it's been exposed to both the flame and the smoke of the substance. With snorting, couple things to keep in mind is on the right-hand side, we've got an example of what can be a snorting kit. So on the top there, you've got colored plastic straws. So if you ever think of like the classic like image of somebody doing cocaine on like the mirror and they're chopping it up with that metal razor blade, if you're chopping it up on glass, what if you crack the glass? What if glass shards are now in that? Also, people have often throughout history used things like glass pipes or even like money rolled up to snort from. Please do not let me have to explain the amount of fecal matter which is on our currency. Do not ever put money in your mouth. Wash your hands after you touch money. It's disgusting. And don't snort things through it. So using a plastic straw is a very easy thing that could be cleaned. It can be color coded. So that way, if you're around a group of friends, everyone can get their own color. It's very easy to figure out who's doing what. So that's a great way to kind of prevent any kind of, infection as well with the color codedness. Also, keeping in mind plastic instead of glass, there's a plastic razor blade there that can be used to crush up the substance. And we want to crush it up as fine as possible. And even if you think it's fine enough, keep going for 5 more minutes, because it might look to be a powder to you, but on a microscopic level, a lot of these substances are big crystals on a microscopic level. And so the bigger the crystal, the more abrasive it's going to be in your nasal cavity, which can lead to lacerations in the nose, blood, things like that. So we want to make sure it's as fine of a powder as possible. And then on the underneath it, we've got our plastic PVC cards. So instead of smashing this on glass, which now we can maybe look at some glass shards, or a surface that is difficult to keep sanitary and clean, a plastic PVC card is an easy thing that can be sanitized with an alcohol pad real quick, and now it's sanitary for you to snort from or grind up on. Again, thinking about aftercare in terms of harm reduction, when we're snorting, we want to think about cleaning out that nasal nose. If the person has the money for it, a neti pot is an awesome tool for this because it'll get all that out, or even a nasal rinse thing, that Dr. Nasal rinse that is at every Walgreens and pharmacy in the world. Use some lukewarm water to get that nasal cavity rinsed out. And then vitamin E is super awesome. I also know it's more expensive than, let's say, Vaseline or other types of lotion. If they can afford it, get vitamin E, put a little bit inside the nose, and that'll help that healing process after the abrasiveness of the substance that's just been snorted, or just a little bit of Vaseline in there to kind of help clean that up a little bit, right? Because we want to heal that nose, because otherwise open pathways, infection, right? All right. We're into the final quarter here, everybody. So let's get to the big part here, naloxone and overdoses. So what's naloxone? Naloxone is also times referred to as Narcan, and it's the opioid overdose antidote. So it is only for that purpose. It's completely harmless. You can drink it if you want to. It's not going to do anything to you unless there's actually an opioid that's bouncing around in your body. It's good for about 2 years. Its half-life is 30 to 90 minutes. I'll explain more about that half-life in a little bit, but keep that in mind there. Sensitivity is extremely rare, which is really important because in that moment of needing to reverse that overdose, you just need to get them to naloxone. And it's very rare for an overdose. The good thing to know too is it's the same dose. Whether or not you are someone who is pregnant, you are a minor, it is the same dose for every person. And again, completely harmless unless there's an opioid in you, right? Or you have one of the rare cases of sensitivity, right? So this is what naloxone does in your body. So here's your little, neurochem lesson for the day. So another way of thinking about this is like Lego pieces. Imagine your brain, and in your brain you have this Lego piece, and that's your opioid receptor, all right? So let's say you just ingested some fentanyl or heroin or some kind of opioid, and now the opioid is entering into your system. And that's another Lego piece. And what are the two Lego pieces doing? They're looking for their partner. They're looking for their match, right? So the opioid goes in, it finds the opioid receptor, and it comes together, right? And now it's entering into your system. It's doing what it does. Naloxone goes in, finds those Lego pieces, not only separates it, but then it puts itself on the receptor. So that way the opioid is just kind of bouncing around. It's still kind of hanging out there, but it's now the naloxone is blocking it. Oh, thanks, Craig. Have a great day. It's blocking it from rebonding to the receptor, which means that it's going to go further lead to an overdose. Okay. This is one of the reasons why we need to think about that half-life. So thinking about medication half-life, it's that point in which half the medication has been kind of metabolized out of the body or gone. So the scary thing about this is, let's say you reverse that overdose and that opioid is just bouncing around in the system. Depending on the person's tolerance and the amount of the substance that's going on here, that naloxone at about 30 minutes is going to get a little rocky. It's going to get a little weak. And as time goes on, that Lego piece is going to lose its hold and it's going to just pop off. Guess what happens? If that opioid is still in the body there, it's going to go right back to its friend, the Lego piece, and rebond again. So that's why, two things. It's important that even though we reverse an overdose and someone's coming back to consciousness, we're still watching them, because there could still be enough of the opioid that's in their body that when that naloxone wears off, they can go back into an overdose again. The other reason why this is important is, depending on, again, those factors of tolerance and whatever the substance was, it could be possible that you need that second dose of naloxone. So you just need to further strengthen that receptor bond there and block those opioids from being able to bond to the receptors. So two reasons why it's important to kind of not just reverse an overdose and leave someone, but actually stay there and watch them for about a good hour or so to make sure that they're not going to go back into an overdose because of the half-life here. I really want to name fentanyl real quick because it is a huge issue in our nation right now. And I don't know where you are and how it is in your part of the country, but here in Chicago, it is a massive issue. In fact, just most recent data reports as of just 2 years ago, our citywide overdose rate, over 90% was just due to fentanyl. So if you're unfamiliar with it, it's a synthetic opioid, much like morphine, but it's about 50 to 100 times more potent. I've worked with some clients who've used it. Really, it's, for that severe chronic pain management when nothing else is happening. It can come in many different ways. So as you can see, it can come in a liquid form, it can come in pill form, it can come in as a patch, like a dermal patch that kind of releases over time. So a lot of different ways that it can be used. And for people that experience that, chronic pain, it gives them that euphoria that they just want to break from the pain, right? And with any opioids, it's going to lead to the possibilities of, difficulty breathing, unconsciousness, constipation. But it's giving them that elation, that sedation that helps with that pain. So it's a very powerful thing. And it's very likely to lead to an overdose if you're using it and you don't know what you're using. So how do you know someone is going into an overdose? Think of blue. All right. First and foremost, breathing. So the breathing is shallow, it's erratic. Oftentimes, this is about less than 8 breaths per minute. So that's another kind of time and frequency, if that makes more sense to you to think about breathing. But the breathing is really shallow. It's very kind of haggard, it's gargling, it's erratic. Look at the lips and the fingertips. Both the lips and the fingertips are areas of the body that as you deplete oxygen in your body, they're going to change color the soonest. So depending on the pigmentation, the melatonin of the skin, the lips and fingertips can be kind of more of a grayish kind of purple, or they can kind of be more of blue. So fingertips and lips, if it's kind of more gray, purple, blue, it's a sign that the body is losing oxygen, okay? Unresponsive, that's a great sign that they're probably going into an overdose because they're not responding to you when you're calling their name or you're trying to, bring their attention to something. And then you also want to look at their eyes. Very, very small black pupils. They're called pinned eyes, pinpoint eyes. So that's another clear sign that someone's going through an opioid overdose is very, very small pinned pupils, okay? Another great way that I like to suggest to people about the unresponsive part particularly is if you're in a situation where perhaps there is a hearing or language barrier, a great way to figure out if someone is responsive is you make a fist and you use your knuckles, you find your sternum, your chest bone, and you just do some gentle pressure and you rub it up and down, okay? Now, I don't know about you, but if I was on the ground or in a chair and I was asleep and someone was doing this to me, I'm going to wake up and look at you and be like, why are you touching me? It's not so invasive that we have to take off somebody's clothes to see if they're breathing or things like that, but it also bypasses any kind of language or hearing difficulties here. So do a quick little sternum rub, even over the jacket of the person if it's winter or fall. And if they're still not responding, they're probably going through something here, okay? All right, so first and foremost, call 911, all right? Now, I want to take a minute here and again, as a social worker, acknowledge the injustices that exist in this world. When we call 911, it is possible that depending on the person that we're calling for, they can be harmed in this process. So I talked earlier about the historical harm against, communities of color, especially gender or trans expensive folk. So calling 911 oftentimes is going to involve a police car, especially if you tell the 911 operator that's an overdose, they're usually going to send a police car afterwards. So you could involve them legally. Financially, especially here in Chicago, the vast majority of ambulances are private companies. Insurances are not paying for this. So they might take them to the hospital and they're probably going to get a bill of $1,500. And then when they get to the hospital, what kind of treatment are they going to get? Especially if they're showing up as somebody who's probably been unhoused for a while, who, is not looking like a cis white person. They're going to get some attitude, I feel like. So best practice is calling 911. I am not going to say it's not. And I also want us to be mindful of what that actually means, okay? One thing I like to suggest to people is if you're calling 911, we call because somebody's unresponsive. They're unconscious on the floor, and I'd like to get a paramedic here as soon as possible. That's what we can start with. We don't need to say there's someone on the ground, maybe as an overdose, there's a bag of heroin next to them. We're setting some things up for that person here, okay? So again, if you suspect, call 911 already. The other thing about that is, especially here in Chicago, I'm sure it's not going to be a surprise to you when I say that calling 911 and the response times towards the communities that are generally of color on the west side, those response times are if not double, 3 times the length than it takes for them to get into other communities, especially white privileged communities. Their response times are a fraction of how long it gets to other communities around here. So that's another reason why you call 911 first, because who knows how long it's going to take for them to come out to you. At that point, we've already called, and so now we're just double checking. Now this is when we're doing the sternum rub. You know, we're checking to see, all right, is this really an overdose here, kind of a thing? Because again, how long is 911 going to take? And if they are unresponsive, we're just going to start giving them the naloxone. So if you've got the injectable naloxone, we'll inject it at this point. Otherwise, we'll use the nasal Narcan. And so let me stop screen share here for just a second so I can kind of show you what this looks like in case you might be unfamiliar with this. So this is liquid naloxone, as you can see, little tiny vial, right? Little tiny liquid in there, and again, that's all you need, a little bit, right? It's got an orange cap on it, which means that this is still secured. Here's one that's my little tester one. This is water. As you can see, the orange cap is not on this, which means that the seal has been broken. So I would not use liquid naloxone that does not have its orange cap on it, because who knows if this has been tampered with, okay? All right. Oh, thank you, Margarita. So when we're using the liquid naloxone, oftentimes we use, we couple it with a intravenous muscle needle, which is like a 23 gauge. You can use, other needle gauges, but 23 is a good standard size, because since we're injecting this intramuscularly, we're going into the thighs, the bicep, and the good old booty. So as we put in our needle, you can see where the water level is on that side. So one hand holds the vial, the other is pulling down on the plunger. So all of the liquid gets into the syringe. Boop, perfect. Now, as you can see, there's a lot of air in here. So we're going to push a lot of that air out to get most of that out. If there's still some air in there, you're okay. Some air is okay, because again, we're going intramuscularly. If we're going into a vein, very bad idea for an air bubble. Stop someone's heart that way. So, but if we're going intramuscularly, get most of the air out, but it's okay if there's a bubble left or so. And then again, we're going right in, right? So the thigh, the ass, or the bicep, okay? So we've injected the person with our liquid naloxone, and now we're watching and we're waiting to see what happens, because a couple things can really happen here. Within a couple minutes, that person's going to start already coming back. You're going to see some coloration on the face. You're going to see the breathing is coming back. You're going to see them starting to become more responsive. That could be one pathway in this adventure story, okay? The other pathway is they're not breathing yet, and so we might have to jump into what's called rescue breathing. It's not CPR, so we're not doing the chest compressions, but we are doing similar in that we are laying them flat on the ground. We're opening up the airway by tilting the head back, making sure there's no obstruction in the mouth, and then we're breathing in to their mouth and just watching the chest rise and fall, but we're not doing chest compressions, okay? The reason why we're doing the rescue breathing is if the person has been unconscious for a good amount of time and you've seen that discoloration in the lips or their fingertips, that means that oxygen is depleted, right? And so we're breathing the oxygen back into their body. Now, if it's someone who just recently went into the overdose, not only are they going to respond back sooner, but you probably don't need to do rescue breathing, because as we become unconscious as humans, we don't instantly lose our oxygen. Our lungs store some measure of oxygen in, and then as we stay unconscious, that slowly leaves our body. So that's when we start losing the coloration in our fingertips and lips. So that coloration is also an indicator of probably how long that person's been in that overdose for, okay? All right, so let's get back into here real quick. All right, so again, if they're not breathing, we do the rescue breathing, just making sure the chest is rising and falling. And if not, we want to get that second dose of naloxone going. So we've given the first dose, we've given some rescue breathing, and they're still not breathing on their own. Let's give a second dose of naloxone. again, it's not going to harm them by giving them a second dose. If anything, it's going to get into the body and also help with that potential of the tolerance, the potency of the substance, and the half-life. So that's why we're going to get that second dose, okay? Finally, once we've gotten that person to the point where they're breathing on their own, if you're familiar with ever somebody who experiences epilepsy or seizures, we're going to put them in that recovery position that you might be familiar with. So it's at one arm stretched out, the other arm is bent, head is on, they're turned on their side with their knee pulled over. And the purpose of this position is that it's a stabilization position. So it's less likely that they're going to be rocking back and forth. Because the scary thing is, even though they're breathing on their own, on their back when you're doing all that, if you leave them on their back, let's say there is an obstruction that happens, or they cough up something, or there's a lot of reasons why that can happen. Get them on their sides. It's a lot easier to keep that pathway open and the less likelihood of choking on anything. Other thing too is I just want to put this out there because I know it's happened in the world. I know it sounds more comfortable to put someone on a couch in this kind of a situation. Don't leave them on their back recovering on a couch, because what can happen is they can roll over and now they're on the floor face down, and now they're, keep them on secure floor in the recovery position. All right. The only thing I want to just mention for the nasal stuff is, again, instead of injecting naloxone, we're just going to squirt it in one nostril. It doesn't need to be into both, but you just spray it all into one nostril like you would any kind of allergy medicine and all that. And then the same thing happens. We're going to watch and see if they're breathing. If not, we're going to jump right into that recovery breathing there at that point. Okay. So the only difference is, instead of sticking a needle in someone, we're sticking a little nasal spray in someone. All right. Some final stuff here. Again, if you've ever been in a situation where you reverse an overdose, you probably know this part. They might not be happy with you. I have had so many curses and fists thrown at me when I've reversed an overdose, and I think I've been up to about 35 right now. It's a scary thing, right? And so why are they waking up like that? Well, first, they could be completely disoriented. They don't know what's going on. Other times, I just ruined their last $60 that they spent on that hit. And now they're pissed at me. And I get that. They wanted that high. I reversed it. And now they're angry at me. I get it. Totally. All right. Oh, Candace, I'm sure. Yeah, definitely experience this. Yeah. And so you want to be aware of that, So what I like to say to people is that if you're in that moment, you're reversing that overdose, don't be right in that person's face looking at them. That is not a good place for you or them to be in. Be a couple feet back, using that tone of voice, that NPR, therapist tone of voice, as I like to refer to it. Hey, how you feeling? Welcome back. How you're breathing. Reorient them to where they're at and everything. The other thing too is that they might want to use again, because again, they just lost their high that they were wanting. So it might be that they want to go back in, try to do anything you can not to let them use anything else, even if it's a different substance, because already there's enough toxicity in the body that led to that overdose. Anything more is going to further toxicity in the body and the potential for a further overdose. So we don't want to add anything else to this right now. Okay. And again, like I mentioned, it's that half-life of the overdose. After we reversed it, please don't leave them after 15 or 20 minutes. Stick around for at least an hour, hour and a half. The other thing too is acknowledging the concerns about healthcare here, and taking people to, let's say, the emergency room or things like that. Is I also want to acknowledge that in some cases you do need the aftercare after an overdose. So for instance, I've worked with many clients who were in their late 50s and 60s with COPD, other health factors. They go into an overdose. Many of them needed that aftercare in order to kind of take care of the other, complications that were going on, because that body just took a big hit. So it might be necessary to get them to the hospital. They don't maybe have to go in an ambulance, but I would suggest that they follow up with their provider as soon as possible afterwards to make sure that, everything else is being checked out. A lot of information, everybody. So How we doing? Questions, thoughts, concerns? Maybe there's some life examples that anyone wants some feedback on. But I was thinking maybe for the last of our time, the 15 minutes here, I can open it up to you and see what do you have.
I think you did a fantastic presentation.
Oh, thank you, Candace. That's very kind of you. Thank you.
Presentation.
Thank you.
And I'm with you with that on the end. If somebody just overdosed, don't be in their face. That is a very bad idea.
Yep. Coming swinging.
Yeah,
Margarita?
I want to echo Candace. That was amazing. And I appreciated that you talked about injectable naloxone and nasal naloxone. I have done a training before for nasal naloxone. So if anyone hasn't used it, like it's almost impossible to mess up. Like it's very easy. But I appreciate that I had not heard about, I mean, I knew there was injectable, but I had never been instructed on how to use it. So I think that's important because we don't know different people, different states, what they're going to have access to. So I appreciate that. I also see Margarita's hand. If you want to go ahead.
And
Yeah.
thank you, Maureen, by the way. Yeah, Margarita. Yeah.
Oh, I mean, I'm sorry I jumped on late, but I work as a senior epidemiologist in our behavioral health bureau at the health department in Chicago, and I'm surprised I haven't met you yet. And I mean, I've been here almost 25 years, and in the health department, but that was, and I'm not like, Maureen knows how I am. I do not tell a lie. Your presentation was like stellar. I can't, right, Candace? Like it was just phenomenal. I mean, I'm not just saying that because I say it. It was the way you described it. I love the what's it called? The organic chemistry thing with it was all of it. It was amazing. Your candidness about the police, about yeah, it's just real because that you have to be, it's not going to stop you from doing what you need to do, but you have to, remember that this could happen and it does happen to certain people more so than others. And I really appreciate that. So, yeah, I can't wait to like meet you in person and have some more collaboration. So, and then if I can assist you in any way. I actually had one question about the data. I actually wrote it down. Where did you get that data? Was it from 2022, over 90% of overdose rate?
Yeah.
Was it
Yeah.
Emmy's office or was it our health department?
Yeah, it was CDPH.
Okay.
Yeah.
So if you can give me the citation, I haven't heard that exactly, but I mean, it's that's why we've had so many, deaths for opioid overdoses,
Yeah.
And now there's a whole nother synthetic stuff that is all new and yeah, so I would love to catch up with you at a later time.
I'd love that. And thank you so much for your truly kind words. I mean, I'm surprised we haven't crossed paths. I did a lot more work in HIV work. I know Tanya, who I know is probably still around at this time. So
that's actually how I started in HIV back in 1999 for another mother to baby transmission. And I don't know if you know Lorna Thorpe, who's in New York City. She
oh yeah.
Oh, so we
Yeah.
go way back. Okay, so yeah. I'm
Oh
just
wow.
maybe I do know you. I don't know. It's weird that I haven't, seen you.
Oh, that's why I love this work, is because it takes a community to work with a community, issue and all that. And I mean, truly, thank you so much for your kind words. I mean, Tracy, Wilma, I mean, Denise, Maureen, Sarah, Deborah. I mean, about all of you are so kind with your kind words here. And I appreciate you like my candidness. Oh.
I put it in the chat, but Joey or anyone else on the call, including Margarita or anyone else, CDPH, can you speak at least to here locally in Chicago how we can obtain naloxone to like have on us in case we need it?
It's super, super simple. We have boxes of them here in the office at 1920 Southwestern. So, I mean, I can connect you with Madeline or some of the other folks who do you know Madeline? She sits a couple feet from me, but generally, you know, the delegate organizations who we fund, I'm sure Joey knows, they have it, but you can get it. You can get one from any of our libraries. There's new vending machines, which, you know, sort of like get back to, I know we're running out of time, but to you know, they require sort of a PIN number, but you can get the PIN number from an, you know, organization. But to be honest, you know, not everyone has access to a smartphone and this and that and all sorts of that stuff. But if you need any, you could reach out to me. I can put my email in the chat, and then I'll connect you. I mean, you can just come in and get some, or you can just go to your local library, or I can send you where the vending machines are, and you can let me know how it is to access them because I'm actually very curious. And the funny thing is these vending machines, if you haven't heard, they have naloxone, but they also have like feminine products, underwear, socks, and tech strips, and other things that we're gonna have soon. But the most that actually gets um, people want the most are like socks and underwear. And I believe like the next one is like feminine products. So not that naloxone is not used, but it's not as highly sought after in the vending machines. But we did a training in Logan Square for some young people. It was really wonderful with Palenque LSNA last week, Thursday. But we just, if you want it, do it. But like by far, your presentation, Joey, was outstanding. So
Oh,
I want to
thank you.
take you.
Well,
Yeah.
we'll meet up after this for sure.
Okay, thank you. If you have any
And
questions, I'll put my name and number in the chat. So yeah, it's very easy.
yeah,
There's
and
also,
Latoya before, yes. Maureen, was that what you're gonna?
I was just gonna lift up the question in the chat from Latoya. How do you start a conversation towards harm reduction with an individual with a purpose to help them? Do you have any tips on that, Joy?
You know what? Again, meeting them where they're at. Not trying to. So, if you ever heard of the concept of, you know, leading the horse to water, don't drag the horse. Just so, hey, there's a pool of water over there. Have you ever considered that? What, you know? Um, One of the things I really like to suggest to people is if you want to start creating these conversations, look into the motivational interviewing. That is going to be one of your best friends. In fact, SAMHSA created the motivational interviewing guide. It's part of their tip series. It is one of the best I've ever read because it boils down each stage and says, these are the questions that you should be focusing on in this moment to elicit the hope for change, the optimism for change, the challenge against the status quo. That's really going to help guide that conversation. But really what it is creating a dialogue and a conversation without judgment, with no shame, and just to kind of be next to that person. And so I would start with something along the lines of, you know, I'm curious to ask, you know, have you ever thought about what it means to engage in that drinking? Like, what does it do for you? Like, you know, how does it help your life? Start there. Start talking about there, because if you start going to, you know, it's doing this, you know, it's doing that, it's like telling the kid no. I'm sure all of us have been told no when we were 5 years old, and we probably did not like that. And the same thing as when adults. We do not like that. We retaliate, you know. So when it comes to that kind of conversation and keeping it open towards the positiveness, the gain that they have towards this, and again, not to judge it, and then to say, what would it be like if that wasn't there? What would it be like if it was 2 days less? You know, ever thought about that? But again, I'm going to be with you right next to you the entire time. So come in it open-hearted with empathy, no judgment, and I promise you, you're going to start off a great conversation that way. And be patient, because again, we do not change very quick. And so you're asking someone to take out something that's helping them navigate their daily life or weekly life, let's say. Okay, let's sit with that. That's not our responsibility to change right away here. Let's sit with our own discomfort, which a lot of times is the biggest issue, I think. And then just to kind of encourage that person, be like, I'm not leaving your side. I'm going to be right here with you. And when you're ready, let's go.
Great
And
advice.
knowing it's a up and down battle.
Yeah.
Did that help? Good. Thank you. Yeah, great question. Thank you for that. Yeah.
I just want to add that, Joey, that was amazing. I also, it's funny because I'm also a positive psychology coach on the side, like, um, but I really do think that, everyone has a lot to learn from everyone else.
Yes.
And I think that, and I know Maureen, I don't even know how you do it, Maureen. You just bring the best speakers and presenters to this meeting. I never want to miss if I am late, but I'm like, you're just amazing. But the thing is, like, it's what you just said. I wrote this down and I didn't have to, but sitting with your own discomfort. I mean, that is for many, especially in public health, it's like they're afraid, but there's nothing to fear. Do you know what I mean? Because it shows when you take the time, like you do, Joy, like when you take the time to connect with people, we actually learn so much from anyone, especially folks that are going through trauma, going through whatever. And at the end of the day, I'm pretty sure that, folks know that they don't want to be using or overusing or whatever, right? So you just have to be with them, and then like let them, let at the pace that they want, that they're ready for. It's awesome. Thank you.
Oh yeah. Yeah. Thanks for the follow-up on that for sure. Yeah, just be next to them. Don't overthink it. Yeah. It's like I teach my graduate students every year how to talk about, sex and sexuality. I tell them, go look at yourself in the mirror and say some of these words out loud to yourself. Watch your face, because that client, that person you're talking to is watching you, trust me. So that little turn of your mouth, that little eyebrow raise when they say crack or, some sexual term, you gotta watch your face at all times. Yeah, the SAMHSA motivational interviewing resource. Yeah. It's about, it's one of their manuals, about like 200 pages long. You can download a free PDF of it, and sometimes you can even get them to send you the physical copy of it. So, yeah, I wish I knew off the top of my head which tip guide it is, but yeah, SAMHSA is a great one for that. And
I can try and find it. We'll see if I can.
Perfect.
All right. Well, I want to once again send so much gratitude out to you, Joey. Really great presentation. We're so honored to have you with us. And I feel like this is really important for everyone, harm reduction, but I think especially for community health workers, when so much of what we do is built upon trust and mutual respect and strong relationships. One of the great things I think about harm reduction is that it can take place across a relationship and it can strengthen a relationship. This idea of only engaging with people when they're ready to stop using a substance, as we said, shuts out a lot of people. But when we, as you mentioned, when we share space with people and we say, that we're engaging and we're building community with them as they are now, meeting them where they are, that builds the basis for a relationship that then we can set goals together to reduce harm in large and small ways. So I really, really appreciate you. I appreciate everyone for being on the call. I did put in the chat our July, and thank you. The link is now, the motivational interviewing link is in the chat. Our July session is going to be in mid-July, so it could be July 17th, 2024, 12 p.m. Central Standard Time. And our guest speakers will be from Make-A-Wish Foundation. So that's going to be a great presentation you do not want to miss. I'll be sending that invite out this week. I'll also be sending a follow-up from Joy's presentation. So Joy, if you have slides or handouts or anything you want to share, you can email that to me. I'll get it out to the group. Additionally, if anyone has announcements, flyers, events that they would like share with the group, please email those to me as soon as you can, and I will try and include it in that follow-up email. Okay, thanks so much, everyone. Enjoy the rest of your day.